This flowchart outlines the traditional nursing process taught in pre-licensure education. It dictates a strict sequential method: assess the patient, plan the care, intervene, and evaluate. This linear sequence functions flawlessly in stable, predictable clinical environments where complications present one at a time. The reality of high-acuity environments is defined by clinical instability and narrow therapeutic windows. In the neonatal intensive care unit, multiple patient systems often deteriorate simultaneously, creating a context where every intervention has immediate cascading effects across the body. Under the pressure of rapid multi-system instability, the traditional linear reasoning model breaks apart. A nurse cannot wait to complete a full sequential assessment when an airway and a cardiovascular system are collapsing concurrently. When novice nurses enter these high-acuity units, they often struggle. But analyzing their performance reveals they don't fail due to a lack of baseline clinical knowledge. They fail because they experience immediate cognitive overload. Confronted with simultaneous emergencies, novices attempt to process every data point at once, causing them to scatter their attention or fixate on isolated tasks rather than managing the overall patient trajectory. Expert nurses navigate the same chaos effectively. They do so by discarding linear checklists in favor of intuitive, rapid pattern recognition, allowing them to anticipate complications before alarms ever sound. To bridge the gap between novice overload and expert intuition, educators must move beyond standard orientation protocols and engineer a unified 5-layer educational architecture. The objective of this architecture is precise: make expert reasoning explicitly teachable, validate clinical competency through diagnostic measurement, and provide calibrated scaffolding. Relying on informal clinical exposure alone is insufficient for these high-stakes transitions. Systematic cognitive engineering provides a structured pathway to transform novice task doers into expert clinical reasoners. The foundational layer of this new architecture is a cognitive engine known as the clinical adaptation spiral. This diagram illustrates the spiral as a continuous, 4-phase recursive sequence. It is explicitly designed to guide the mind through managing unstable clinical events without losing focus. It begins with the anticipate phase. This demands proactive risk stratification. Rather than waiting for a threshold violation, the nurse must predict complications based on risk factors, forcing them to think in forward trajectories rather than isolated snapshots. Next is the stabilized phase. This directs the execution of prioritized interventions based strictly on physiologic logic and system dependencies, treating thermoregulation before glucose management, for example. The third step is the protect phase, focusing on anticipatory harm reduction. Here, the nurse is forced to identify what secondary complications their own stabilizing treatments might accidentally cause. Embedding safety thinking directly into the acute response differentiates this framework from standard task checklists. It ensures harm prevention is an active, named component of clinical reasoning. Finally, the reassess phase closes the loop. The nurse evaluates the patient's response and makes an explicit decision on whether the intervention worked, dictating the strategic step that comes next. To see how this functions in practice, we can track the timeline of a deteriorating septic 32-week infant. In the first 30-minute cognitive loop, anticipating sepsis risk leads the nurse to stabilize the infant's temperature. Simultaneously, in the protect phase, they restrict bolus fluids to avoid secondary volume overload in premature lungs. Moving into the second 30-minute loop, a reassessment reveals worsening respiratory status. This immediately triggers a new, rapid stabilization phase involving CPAP application. By the final 30-minute loop, the patient stabilizes physically. The nurse's cognitive focus shifts seamlessly to protecting against delayed complications like thrombocytopenia and feeding intolerance. This recursive cognitive engine actively prevents clinical deterioration by forcing the nurse's thought process to match the dynamic, evolving rhythm of high-acuity patients. But a reasoning framework serves no operational purpose if educators cannot objectively measure a novice's ability to execute it. Traditional simulation debriefings fall short here. They typically evaluate whether a learner completed a list of basic tasks, rather than measuring their genuine reasoning capacity. The second layer of the architecture solves this by integrating the Donna-Wright competency model. This evaluates the learner's cognitive execution over mere performance theater. This matrix shows how educators grade the learner using behaviorally anchored performance criteria, mapping the 3 right competency columns directly against the 4 phases of the spiral. In a simulated scenario, a learner might score independent on anticipating risk, but simultaneously score unable to perform safely on protecting against secondary treatment harm. Applying this specific scoring system transforms vague simulation debriefings into highly precise diagnostic outputs. It eliminates generic pass or fail grades entirely. Instead, educators use the data to build a highly targeted learning plan, focused solely on the specific phases where the learner struggles. Mapping competency metrics directly to a reasoning loop gives educators the exact coordinates of a novice's cognitive gaps. The third architectural layer transfers that diagnosed simulation data out of the classroom and into real-world clinical preceptorship, utilizing the Beth-Ulrich scaffolding model. This data handoff protocol is critical. The Donna-Wright simulation assessment flows directly into the preceptor's daily coaching log, explicitly defining what the learner needs to practice at the bedside. The preceptor analyzes this specific data to calibrate their level of intervention for the shift, determining whether the learner needs direct hands-on supervision or simply a monitored safety net. Yet even with a targeted plan, the bedside reality is volatile. Novices frequently lose their cognitive organization during sudden, unexpected high-acuity events. Consider a sudden code-in-room scenario. Here, the preceptor must actively manage the learner's cognitive load in real time. As the code begins, the learner panics. They scatter their attention, grabbing a bag mask, dropping it to check oxygen tubing, and losing focus on sequential priority interventions entirely. The preceptor intervenes strictly verbally. They use the named phases of the clinical adaptation spiral as cognitive anchors to ground the scattered learner. The preceptor prompts the learner, asking them to explicitly state their physiologic priority within the stabilize phase before they take any physical action. This targeted prompting prevents the learner from freezing. It builds long-term structured vigilance, and it does so without the preceptor having to physically take over the task. Applying structured clinical scaffolding in this way turns high-stress patient crises into productive cognitive training rather than traumatic, overwhelming failures. The completed 5-layer framework combines spiral pedagogy, the recursive reasoning engine, Benner's developmental trajectory, Wright's validation matrix, and Ulrich's clinical scaffolding into a single cohesive unit. While this architecture was successfully instantiated in the neonatal intensive care unit, its mechanics are not exclusive to neonatal care. The system scales because it intentionally separates the structural architecture of how nurses learn from the clinical content of what they treat. This illustrates the framework's modularity. By removing NICU-specific variables from the architecture, the base structure remains intact. Emergency department variables, like trauma triage, slot seamlessly into the exact same framework. Oncology variables, like neutropenic sepsis, utilize the exact same competency validations and coaching tools. While the behaviorally anchored criteria and coaching scripts adapt to the unique specialty, the underlying cognitive engine remains identical. Standardizing this architecture across an entire organization creates a unified, shared reasoning language for all educators, preceptors, and administrators, regardless of their department. Functioning at the enterprise level, this system provides a fully compliant, T-TAP-aligned blueprint for transition to practice programs. True clinical readiness is never achieved simply by exposing novices to medical chaos. It is achieved by meticulously engineering the exact cognitive structures they need to master it.